This recording is the somatic nervous system, part 4 of 4, pathways, reflexes, and disorders. When we look at sensory pathways, we remember that there are usually 3 neurons involved. There's a first-order neuron, which is the sensory neuron located in the periphery that carries information to the central nervous system. The second-order neuron usually carries information from the spinal cord or the medulla oblongata to the thalamus. The third-order neuron is going to take information from the thalamus to the post-central gyrus, where we have the primary somatosensory cortex. When we look at the sensory homunculus, which you've seen previously, understand that this is simply a map of somatosensory receptors of the body that have been mapped onto the post-central gyrus, which is the primary somatosensory cortex in the parietal lobe. And more sensitive areas, like the hands and the face, are portrayed by larger areas depending on the number of somatosensory receptors. Throughout this slide series, we're going to talk about different disorders, and face blindness, or prosopagnosia, is a condition where people have either an underdeveloped portion or an injured portion of their brain, which prevents them from recognizing the faces of very highly recognizable people. So people who may be celebrities or famous people in history, family members, even themselves in a mirror. When a person has prosopagnosia, that person has a very difficult time recognizing other individuals. And this is a condition, again, that can be present at birth or can occur due to brain injury. Usually people with prosopagnosia have to use other cues, such as voice recognition, hair color, hairstyle, or unique mole or tattoos on other areas of the body that they may use to recognize individuals. I've heard it said, and I do not know that this is true, but I've heard it said that Brad Pitt actually has prosopagnosia. Again, I don't know if it's true, it's hearsay. We know that our motor functions are controlled by the primary motor cortex that's located in the precentral gyrus, which is part of the frontal lobe located just anterior to the central sulcus. And the frontal lobe is where we find not only the primary motor cortex, but also motor association areas, which include the premotor cortex and supplementary motor cortex. You don't have to know those specific names for the motor association areas. Just know that they help plan in terms of coordinating motion that's going to be sent out through the primary motor cortex. And in the frontal lobe, we also have a prefrontal association area, which also helps coordinate information from other association areas that can contribute to what we do in terms of motion. So these prefrontal association areas serve in cognitive functions that can also help determine our personality, short-term working memory, and consciousness. So it includes executive functions that lead to goal-directed behaviors. Again, our working memory, so we can organize information that's not in the immediate environment, but we have stored just recently. Our aspects of attention are actually formed in the prefrontal association area, so inhibiting distracting thoughts while focusing on a goal. That's all done in the prefrontal association area. And functioning is integral to a person's personality because it's basically, this portion of the brain is responsible for what we intend to do as individuals and how we accomplish those plans. Was actually a famous case of a gentleman who worked on railroads using a tamping rod, which is about 3.5 feet in length and anywhere between 13 and 25 pounds. He was using the tamping rod to pack down gunpowder into some rock to blast the rock. And the gunpowder ignited, and this rod went from underneath his left cheekbone through his skull, damaging his prefrontal cortex. And after the accident, people said that his personality changed. He used to be a hardworking, nice person who turned into somebody who was a lot more irritable and had tendencies to be lazy. And this happened again in 1948. They say, we don't know who they are, but it is said that he recovered completely. I don't know what that means if his eye was damaged, and I don't know if that ever recovered. However, they did say that he was able to speak and move normally after that. He did die, I believe, 12 years after the accident. He was having epileptic seizures, which would probably be a result of the trauma that happened to his brain. So even though he supposedly recovered completely, he did start having epileptic seizures. And apparently, from working as a railroad worker in Vermont when this happened, he was able to get a job as a stagecoach driver. I think it was about 7 years after this accident, as his brain was still, recovering in Chile, and then he moved to California, I believe, to live with his mother and his sister prior to his death. And he was 36 years old when he passed. Another look at the primary motor cortex. Here's the motor homunculus. You can see a lot of motor information goes to our hands and our face. A lot of communication. In fact, I think it's anywhere between 80 and 85% of all communication is nonverbal, because we have a lot of nonverbal cues that we generate with our facial expressions, as well as with tonality of voice. So again, the primary motor cortex is located in the precentral gyrus prior to the central sulcus, which separates the frontal lobe from the parietal lobe. And the homunculus is basically a topographical map of that cortex, showing what portions of the body receive what information and from what part of the cortex as well. More space is given to areas that require fine, agile movements, such as the fingers and the lower portions of the face. The secondary motor cortices help produce movement by assisting the primary motor cortex, and the neurons of the secondary motor cortices are going to be more active when initiating a movement. These include the premotor cortex that you can see in blue. That helps to aid by controlling motion of our core muscles, helping us to maintain our posture so we can move more efficiently. And the supplementary motor cortex, which is responsible for planning and coordinating movement. It also helps to manage sequential movements based on prior experience. Other secondary motor cortices include the frontal eye fields, which are responsible for moving the eyes in response to visual stimulus. Also, Broca's area of speech, which is thought to be only on the left side of the cerebrum. We talked about the fact that descending pathways are motor, efferent, and they include 2 neurons. Sensory is 3, motor is 2. When we look at the cerebral cortex, which is an upper motor neuron, we see that the neurons, their soma have a special name. They're called Betz cells. So the soma and dendrites live in the cortex. They have a special name. They're called Betz cells, and they will have axons that travel downward to synapse either with neurons in the spinal cord, which we've seen before when we saw the neurons in the anterior horn of gray matter. They can also synapse with lower motor neurons in the brainstem, and those are the neurons that are cranial nerves with motor function. So upper motor neurons are going to be up here. Lower motor neurons either in the spinal cord in the anterior horn or portions of the brainstem where the second lower motor neuron is going to exit from the brainstem to go serve skeletal muscle as part of a cranial nerve. So there are basically two descending pathways. We have the corticospinal pathway, which we've already looked at with the axons that go all the way down to the anterior horn of gray matter, and then the lower motor neuron takes information to the skeletal muscle. The corticobulbar tracts refer to the synapse with motor nuclei of cranial nerves that are going to exit the brainstem to go to the skeletal muscles for cranial nerves. So those are the two tracks. Upper motor neurons start up here in the cerebral cortex. Lower motor neurons could be brainstem, spinal cord, to the muscle. Now you'll notice, and I want to point this out because this is pretty important information, see how the axons that are coming from the cerebral cortex will travel downward as they descend, and you'll notice that most of these axons are going to cross over to the opposite side of the medulla oblongata at an area called the decussation of the pyramids. The pyramids are tracts, which are collections of axons going in the same physical direction, and they actually cross at some point. Now, not all the axons cross. About 80% of the information goes to the opposite side, which is important because what if there was some hemorrhage on this side of the brain? That could cause paralysis on the opposite side of the body that is very notable. However, remember that there's still information from the opposite cerebral hemisphere that goes to this side. And even though it's not a lot, that 20% coming down the same side can be rebuilt. And that's how they do rehabilitation with people who have had strokes. They work on the side that's been affected to rebuild neuronal pathways and really enhance that 20% that could function again. Technically, the upper motor neurons include the pyramidal cells of the cerebral cortex, which are also known as Betz cells. A lot of texts will also include upper motor neurons as being the neurons in the basal nuclei, which you'll remember are the putamen, the globus pallidus, and the caudate, because the basal nuclei is responsible for modulating the activities of the cortex. So those are upper motor neurons. The lower motor neurons are the ones coming from, again, either the brainstem or the motor neurons that have their cell bodies in the ventral horn of gray matter in the spinal cord. So lower motor neurons go directly to skeletal muscles. Upper motor neurons are coming from somewhere in the brain, either the cortex or the subcortical nuclei, which we know are the basal nuclei. Now, if there is damage to an upper motor neuron, that will cause something known as spastic paralysis, where the muscles just contract really hard. If damage occurs to a lower motor neuron, then that will cause flaccid paralysis, where there's just no tone at all. So upper motor neuron, spastic. Lower motor neuron, flaccid. Upper motor neuron, spastic paralysis. Lower motor neuron, flaccid paralysis. It's still a form of paralysis, it's just one is really stiff and the other one is really floppy. When we look at somatic motor paths, there's an indirect path and a direct path. The direct path involves the corticospinal tracts, remember, from the cortex of the cerebrum to the anterior horn of gray matter in the spinal cord, and the direct path deals more with individual muscle groups for precise movements of arms and legs and hands and fingers, like writing and knitting. Whereas indirect paths involve extrapyramidal tracts, and all other tracts are included in this. And this is where we've got groups of muscles acting together for maintaining balance and posture. It includes axial muscles and coarse limb movements of the arms and legs for running, and it also involves movements of the head, neck, and eye that follow objects. As we look more closely at the corticospinal tract, we can see the soma of these neurons, these upper motor neurons residing in the cerebral cortex. Their axons are going to project downward in a descending fashion because they're carrying descending efferent motor information, and the right motor cortex has information that's going to the left side of the body. At least 80% of its information is going to the left side of the body. We do have about 20% that stays on the same side, which is what we call ipsilateral, is same side, contralateral is opposite side. So as these axons descend, they're going to travel through cerebral peduncles first, then they go through the pyramids and the medulla oblongata, then through the decussation of the pyramids, where those axons cross to the contralateral or opposite side of the body, continuing through the lateral corticospinal tract to synapse with a neuron in the anterior horn or ventral horn of gray matter in the spinal cord, where that lower motor neuron will carry information to skeletal muscles. Now, the lateral corticospinal tracts basically control our appendages, our arms and legs. Our anterior corticospinal tracts control the muscles of the trunk. Extrapyramidal controls. These include other tracts like the tectospinal tract, which helps us produce postural movements driven by the superior colliculus, the reticulospinal tract, which helps influence the trunk and the proximal limb muscles related to posture and motion, and also contribute to muscle tone. The vestibulospinal tract also allows for posture and movement to be balanced and modulated on the basis of equilibrium from our vestibular system in our ears. And then finally, the rubrospinal tract helps correct any kind of conflicts that are going on between motor commands and body position. These extrapyramidal controls are strongly influenced by the basal nuclei, the thalamus, as well as the cerebellum. So there's a whole bunch of stuff going on. It's not as simple as, oh, this one goes down to here and then you're done. There's a concert of effort that's going on in the body in order for us to have motion that's efficient. This is going to take us to spinal cord trauma. The spinal cord itself, traveling down through the vertebral foramen, is very sensitive to direct pressure, and anyone with injuries has to be monitored for what's known as spinal shock, where they might have a period of functional loss, or which might include depression of reflexes that are below caudal, below the level of injury. And it may not be just a depression of reflexes, it may also be a depression of skeletal muscle contraction, or sometimes it could be loss of bowel or bladder function. So if loss continues for more than 48 hours, if there's injury that contributes to functional loss, that's usually permanent. Localized injuries can lead to functional loss. If there's damage to the dorsal root, remember where the dorsal root ganglion was? That could lead to paresthesia, which is just an abnormal sensation. Anesthesia means without sensation. Paresthesia means just that there's some kind of abnormal sensation. Might be stinging, burning, numbness, pins and needles. Those are all different types of paresthesia. If there is damage to the ventral roots, remember that the ventral roots are going to carry motor information, so that could potentially lead to paralysis. So if we look at different types of injuries, any injury to the spinal cord at the level of C4 could lead to tetraplegia from the base of the neck down, where the person is paralyzed from that point down. At the level of C6 below, it's still tetraplegia. However, the person might have some sensation on the top of his shoulders. An injury at T6 is usually going to include the trunk and the lower extremities, while the person may have function of arms and sensations in the chest, head, and neck. An injury at the level of L1 can cause a functional loss of the lower extremities. If there's a transection of the spinal cord where it would be cut across, that could be total motor and sensory loss inferior to the site that's damaged. Quadriplegia is loss of movement and sensation in all four limbs. Paraplegia is loss of movement and sensation in the lower half of the body. Hemiplegia is loss of sensation on one side of the body. So if the patient's left side of the body was paralyzed and had no sensation, that would be a case of hemiplegia. Again, between T1 and L1, that's where we see paraplegia. With the cervical region, injury in the cervical region could lead to quadriplegia, and usually some kind of brain injury like a cerebrovascular accident, which is a stroke, would cause hemiplegia. The term paralysis means that there's a loss of motor function, and with upper motor neurons, when we see damage in those neurons, that leads to a condition known as spastic paralysis. And it's usually due to damage of the motor cortex. With spastic paralysis, we'll also see what are known as pyramidal signs, which are exaggerated reflexes known as hyperreflexia. And this is also seen if a person gets tetanus. If you've ever heard of somebody getting a tetanus shot, usually if that person got a cut from a rusty nail where tetanus toxins may be, that tetanus toxin blocks the release of inhibitory neurotransmitters. And so that causes the upper motor neurons to continually send signals to the lower motor neurons to contract. Lower motor neuron lesions cause flaccid paralysis, and it's usually due to damage to the ventral root or the ventral horn, where the impulses don't reach the affected muscles that are innervated by those nerves. And with a lower motor neuron lesion, we see absence of reflexes, absence of willed movement, and atrophy in muscles because the muscles aren't contracting, they will lose mass. They'll lose proteins inside the myofibrils. And botulism toxin is used to block the release of acetylcholine at the neuromuscular junction. And that keeps muscles from contracting. So if you see somebody who's got cerebral palsy, where that person's in a highly contracted state, that is often treated with injections of botulism toxin to help those individuals allow their muscles to relax. And sometimes people with hyperhidrosis, which is a condition of producing too much sweat, especially for those who have to go into social situations. Imagine having to be a salesperson shaking someone's hand, and that hand is just full of sweat all the time because they've got this condition known as hyperhidrosis. That can be treated by injecting, just at the level of the dermis, injecting Botox to temporarily paralyze the sweat glands. And just like regular Botox injections, it usually has to be done repeatedly over a period of months to continue the effects. The botulism toxin, Botox injections, are also what you see when people have Botox injected into their facial muscles to keep them from contracting. Poliomyelitis was a condition that caused inflammation of the spinal cord due to poliovirus that was found in fecal contaminated water. And this happened in the United States in the late 40s, early 50s. And polio would cause paralysis after fever, weakness, and headaches were experienced. We've since had vaccines developed that have nearly eradicated polio. And people who got polio would sometimes also experience what they call post-polio syndrome later in life, where they had lethargy, muscle pain, and atrophy of their muscles. Amyotrophic lateral sclerosis, which is ALS, also known as Lou Gehrig's disease, is a neuromuscular condition where there's progressive destruction of the neurons in the anterior or ventral horn of gray matter in the spinal cord, as well as the fibers of the pyramidal tracts, which are the axons in the pyramidal tracts. And there are different theories as to why this may occur. Some say it's due to toxins, viruses, or metals. Others say it's due to genetic factors, including superoxide dismutase 1 or other genetic risk factors, maybe due to alsin and acetaxin. So there's different ideas as to why this may be happening, but they do know that it's usually caused by spontaneous mutations due to genes involved in RNA processing becoming mutated. Also, they know that excess glutamate can cause excitotoxic cell death, and people with ALS or Lou Gehrig's disease lose their ability to speak, swallow, and breathe. They're often confined to wheelchairs, and they usually are deceased within 5 years. So we see a lot of different things going on with ALS. There's neuroinflammation, oxidative stress, apoptosis, which is programmed cell death, abnormal aggregation of proteins, the dysfunction of the mitochondria, and impaired axonal transport. Axonal transport, by the way, is just the neuron's ability to transport neurotransmitters that it produces in the soma down along the axon. It uses neurofibrils, which are nerve fibers, to help transport it down the lane, down the length of the axon, like a little train track. So they have anterograde axonal transport, where it goes from the soma to the axon terminal, and then they have retrograde axonal transport, where it goes from the axon terminal back up to the soma, where it can be recycled. Cerebral palsy is a condition where voluntary muscles are either very poorly controlled or are undergoing spastic paralysis. It's usually due to a lack of oxygen that might occur during delivery. For instance, if the umbilical cord gets wrapped around the infant's neck on delivery, then that can cause that oxygen deficiency. Usually, once this occurs, the effects are irreversible, and people with cerebral palsy may have to endure things like seizures, speech, and hearing impairments, as well as this spastic paralysis of their limbs. And this is one of the largest causes of physical disability in kids. About 3 in every 1,000 births is going to have cerebral palsy. Remember, upper motor neuron lesions cause spastic paralysis. Lower motor neuron lesions, flaccid paralysis. Upper motor neuron lesions, spastic. Lower motor neuron lesions, flaccid. Spastic, up, flaccid, down. Upper motor neuron lesion, lower motor neuron lesion. Anencephaly is a condition where the cerebrum, and sometimes the brainstem, but always the cerebrum, does not develop due to failure of the neural tube folds to fuse. This leaves the child in a vegetative state where no movement is possible, mental life is not possible, and unfortunately death occurs soon after birth. Reflexes are automatic responses to a stimulus. They help us maintain homeostasis, and most occur without involvement of the brain. There are inborn or intrinsic reflexes, which provide a rapid, predictable response to a stimulus, and postures of these intrinsic reflexes include posture avoiding pain by moving our body in ways to avoid it, controlling our viscera, and chewing. We also have learned or acquired reflexes that result from practice and are enhanced by repetition. For instance, you can acquire reflexes for riding a bike, driving a car, playing a piano. Those are all examples of learned or acquired reflexes. Monosynaptic reflexes are reflexes that occur when there's just one synapse involved. In the case of a stretch reflex, which is a great example of a monosynaptic reflex, we see that the muscle is simply going to contract in response to a rapid increased stretch. So the stretch reflex, which is sometimes referred to as a tendon reflex, basically helps provide automatic regulation of skeletal muscle length and helps us maintain muscle tone and posture. These are same-sided or ipsilateral, because you remember the term ipsi means the same. So these are same-sided reflexes, and the receptors for stretch reflexes are going to be the muscle spindle fibers located in the muscle belly. So here we have a reflex hammer striking the patellar tendon, which is going to cause a quick stretch in the quadriceps femoris muscle group, where the stretch receptor again is the muscle spindle fiber, and that sensory receptor is going to send information along the sensory neuron that has its soma in the dorsal root ganglion. That sensory information comes in through the dorsal root, comes up through the gray matter of the spinal cord, and synapses with a motor neuron at that same level of the spinal cord in the ventral horn of gray matter. That motor neuron will carry information out, causing the muscle to contract. And so in this instance, the quadriceps femoris muscle group is the effector for this particular reflex. Sometimes in circumstances where there may be damage to a peripheral nerve or to the ventral horn or anterior horn of gray matter in the spinal cord, that can cause reflexes to be hypoactive or absent. Reflexes tend to be absent, stretch reflexes tend to be absent in people who have chronic diabetes, neurosyphilis, or maybe in a coma. They tend to be hyperactive in individuals with corticospinal tract lesions. So again, upper motor neuron lesions not only causes spastic paralysis, but also causes hyperactive reflexes or hyperreflexia. This picture shows how diabetes can affect nerves. We see that blood vessels have to supply the neurons and the axons and the Schwann cells with oxygen and nutrients, and having a condition of diabetes and thick, sticky blood means that it's harder to get blood through blood vessels, and the blood cells tend to stick to the blood vessel walls, and it damages the blood vessel walls, and that ends up causing disease within the blood vessels. And when the blood vessels become damaged, then the nerves are basically going to start to shrivel when there's no more fresh oxygen and nutrients, and the cells can't get rid of their carbon dioxide and waste products. A polysynaptic reflex is a reflex that has more than one synapse. And flexor reflexes or withdrawal reflexes are very good examples of polysynaptic reflexes. A response is a rapid withdrawal, which usually involves the act of flexion, and that's why they're called flexor or withdrawal reflexes. If we look at this picture, we can see that sensory receptors are going to have pain information that ascends, and it's going to go to the brain. However, at the level of the spinal cord, this information is going to synapse with an interneuron, and the interneuron will connect to the motor neuron. So we've actually got 3 neurons involved, 2 synapses between the two. We have the sensory neuron, which forms a synapse with the interneuron, which forms a synapse with the motor neuron. So 2 synapses, 3 neurons. This is also an ipsilateral or same-sided reflex. The receptors here in this case are nociceptors in the skin, free nerve endings, and this helps protect us from further damage to the tissue. So the response actually occurs. This input and output of motor response takes about 20 milliseconds to occur. This takes us to a cross-to-extensor reflex. This is where we actually get a contralateral or opposite side response. For example, if you were to step on a tack, your flexor reflex would pull your affected foot away, while your cross-extensor reflex straightens the opposite leg to help support your body weight. Walking is a prime example of cross-extensor reflexes because as we extend one leg, we have to bend the knee, flex the opposite leg, and then it switches. So there's a constant cross-extensor reflex being used. In this particular picture, the site of stimulus is if this guy is pulling on this other person's arm, okay, this guy is pulling on the arm with the hand that's green, okay, and as he pulls, the reflex is to flex to remove the arm away from the hand. So one side of the body flexes, however, the opposite side of the body will actually extend. So that is what we call a cross-extensor reflex. And again, we can see the initial stimulus going in this light blue on the afferent fiber. It goes in, it synapses with interneurons. One of the interneurons crosses to the other side, and those interneurons is going to stimulate, those interneurons are going to stimulate the motor response for the opposite limb, one of which is stimulating the extensors while also inhibiting the flexor muscles on the anterior aspect of the arm, because we can't have them both contract at the same time. So if flexors on one side are stimulated, the extensors are inhibited, and if the opposite side is going to have extensors stimulated, that means the flexors are inhibited. Superficial reflexes are reflexes that are initiated by the stimulation of skin. There are plantar reflexes, which test the corticospinal tracts from L4 to S2, and abdominal reflexes test roughly T8 to T12. And the normal plantar response when the skin of the foot is stimulated on the lateral aspect and stroked toward the toes and then swiped in medially toward the big toe, the normal plantar response is going to be toes go down in flexion. However, in infants, because infants don't have a well-developed nervous system, what we see is called a Babinski sign or a Babinski response. So the Babinski is for the babies, where there's fanning of the toes and the big toe goes upward in extension. The abdominal reflex can be done in lots of different ways, and normally a practitioner will take some kind of edge of an instrument that won't scratch the skin and just stroke in all four quadrants, either towards the umbilicus or away from the umbilicus. And there should be contraction of the abdominal muscles just deep to the skin that are noted on both sides. If it's not noted on both sides, that could indicate a problem. Other common clinical reflex tests, well, we just talked about the plantar reflex and the abdominal reflex. Those are both superficial reflexes. And then we have stretch reflexes or tendon reflexes with the patellar reflex, as well as the Achilles tendon makes another good place to test reflexes because it's an easy one to tap and elicit a reflex. For the patellar reflex, when the quadriceps femoris muscle group contracts, that's going to cause the knee to extend. In the use of the Achilles reflex, when the Achilles tendon is tapped, that should cause plantar flexion of the foot at the ankle. Autonomic reflexes are reflexes that include smooth muscle, cardiac muscle, and glands. All are polysynaptic, and examples of these types of reflexes include things like sweating, shivering, increased heart rate due to the fear of an anatomy and physiology exam or a bear, the dilation of pupils when we are in a dark environment. Our pupils will dilate reflexively to let more light in so we can see better. Conversely, if we go outside where the light is bright, the muscles will cause constriction to decrease the amount of light that enters the eyes. These are all types of autonomic reflexes. So what happens as people get older, and how does that affect the peripheral nervous system? Well, it's noted that sensory receptors will start to atrophy, which means that muscle tone tends to decrease as people age. That means reflexes will start to occur more slowly, and proprioceptors start to become lost due to the inactivity, and that may lead to falls, broken hips. There also tends to be a loss of neurons and fewer synapses and slower processing within the central nervous system as well. So in terms of the brain and how that is affected, brain volume and weight will decline steadily from the time people are in their 30s until they are deceased. After the age of 70, there tend to be some declines in cognitive abilities, so recognizing things, perception, speed, decision-making, reaction time, working memory. However, math and verbal skills and building on experience actually do not decline. Dementia is often caused by prescription drug side effects, low blood pressure, poor nutrition, depression, hormonal imbalances, and dehydration. Dehydration is a real big problem with the elderly. A lot of them don't drink enough. And oftentimes they may be taken to the emergency room because the person may just be really out of whack and just Granny needs some IV fluids. So it's important to make sure that elderly individuals get good nutrition, get exercise, and hydrate. Boxers and alcoholics do tend to experience more decline in their brain volume than other people because of the repeated trauma that boxers get in their chosen profession. And alcohol tends to damage neurons. Remember, it can easily cross the blood-brain barrier because it's fat soluble. That is the last slide for this information.